Hello, and welcome to ROSA's Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at ROSA, and I'm happy you've joined us today. Just a reminder, during today's webinar, you can enter questions for the speaker by clicking on the Q&A button at the bottom of your screen. The speaker will address questions at the end of the webinar. If you're interested in being a speaker, please reach out to us on the website. We're always looking for new webinar speakers. Our speaker today is Irina Kareva. She's the founder and principal at Quercus Insights. She received her PhD in Applied Mathematics for Life and Social Sciences from Arizona State University and did a postdoctoral fellowship at Tufts Medical Center in Boston. Previously, she worked at EMD Serono, and her research has focused on mathematical modeling of cancer as an evolving ecological system, with particular focus on applying insights from ecology and evolution to understand cancer initiation and progression. Welcome, Irina, and we look forward to today's presentation.
Thank you so much, Mike. And thank you everyone for being here. I'm not going to be talking too much about cancer ecology and evolution today. Instead, I'm going to talk to you about combination therapy and synergy. So I'm going to turn off my video, not to be too distracting. Okay, here we go. The promise of combination therapy in oncology. This has really been a big topic through the last half a century. It's been a major promise in drug development since the 60s, when the first combination, the VAMP combination chemo protocol, was developed for pediatric ALL. We have MOB-Hodgkins, we have CHOP for non-Hodgkins, still used today, obviously, as well as many attempts to also find combinations that will work better. And the goal of combination therapy really is finding rational cancer treatment combinations. So trying to find agents with different mechanisms of action to bring multiple independently acting drugs together. When we're talking about and thinking about combination therapy, we can focus on two types of questions. We can ask about which drugs to combine, and we can wonder and ask how to best administer them once a combination has been selected. These are different types of questions with somewhat different methodologies, and the one that I'm going to focus on today is the second one. Okay, so we have a common problem. We have preclinically promising combinations that keep failing in the clinic. One example is, for example, inotuzumab and erlotinib in non-small cell lung cancer. Preclinically, looked quite promising. Yes, you could see that the combination was working quite a bit better than either agent alone. And there is a logical mechanism behind it. It went into clinical development, and early clinical data looked promising, but okay, we're now starting to see maybe there's a subgroup of MET-IHC positive tumors that will respond better. MET negative tumors did not benefit, but that's okay. Again, we're trying to figure out what might work. Unfortunately, scale-up failure in phase 3, the combination did not improve outcomes. Another example, selumetinib and docetaxel in KRAS mutant non-small cell lung cancer. Here they were specifically even talking about preclinically very promising synergistic effect of these two drugs in a colorectal cancer mouse model. Early clinical signals were promising also. So randomized phase 2 trial actually motivated phase 3 escalation. This is a quote from here, like, has promising efficacy, warrant further clinical investigation of the combination. And once again, scale-up failure in SELECT-1, the combination did not improve progression-free survival versus docetaxel. This is not uncommon. We all know these stories. And I wanted to kind of dive into, at least in combinations, at least when we're talking about synergy, why this is happening. Maybe there's somehow we can think differently about this. Because in both cases, there was a strong mechanistic rationale for the combination. There was a strong preclinical synergistic signal, and there was even promising phase 1 and 2 data. But this keeps happening. We're all very familiar with this sad funnel of decrease in the likelihood of success as we are going into real patient populations. So before kind of going into this, I want to zoom out and talk about, so we saw synergistic signal. What does that actually mean? This is not as trivial a question as may seem at first. So before we kind of talk definitions, I want to go through a thought experiment. Imagine you have two people painting a room, and one person can paint 40% of the room in 3 hours, random numbers. Somebody else can, and the second person can do the same in 4 hours. So if you look from point of view of output, which is how much of the room gets painted, if one person works for 3 hours and the second one works for 4 hours, and you get only a quarter of the room painted, that's clearly antagonism. It's worse than either could have done separately. If the entire room gets painted, it's clearly synergy. Fantastic. But what if you get 60% of the room? Also, you can look at it from the point of view of input, which is how much time everybody worked. If you're getting 40% of the room painted and requires 10 hours of combined work, obviously it's antagonism, much longer than anybody would have put in. Separately, 1 hour of combined work, obviously synergy. But 3.5, which one is it? And this is kind of the point with all of these metrics. At the extremes, what is synergy and what is antagonism is very clear. But it's the intermediate cases that get much trickier. So how do we quantify combination effects? First distinction that I would like to make is that there is a colloquial kind of meaning of synergy. Yes, the whole is the greater than the sum of its parts. And that's what we typically think of. And then there's scientific meanings, where you actually put numbers on things. And obviously, that's the one I'm talking about today. Synergy, by definition, is defined relative to additivity. So we all know this, this little graph. And synergy, relative to additivity, is when combined effect is greater than what is expected in the additive case. So this whole 1 + 1 greater than 2, versus antagonism when the combined effect is less, what is expected in additive case. Well, the thing is, there is no one definition of additivity. And that's because additivity does not simply mean adding things. Like if you have one drug that kills 60% of cells at one dose, and the other one kills 2% of cells, it does not mean that when you add them, you get 110% kill. And so people have been talking about it and struggling with it and trying to make sense of it and gone to war over it and come up with an overwhelming number of definitions in the literature. I'm not going to go, obviously, through them, but there are two main classes of metrics into which most of these definitions fall. One way, as kind of was hinted to and alluded to in the painting examples, to look at is from the point of view of output. And we call it kind of synergy of efficacy, of synergy of output. The two main metrics, I'm just giving an overview. You do not obviously need to remember this. This is kind of just building the pieces that are necessary for the coming story. But the most common metric here is Bliss additivity, which assumes that additivity is defined by dose independence. And I'm not going to go through the math of how this is derived. It's very easy to find. But the point here, this is a very high bar for additivity. So it's very actually hard to have to have an output that is classified as Bliss additive and synergistic. By contrast, there's highest single agent model, and that assumes that assumes additivity if efficacy of combination is at least as good as the most efficacious monotherapy. And this actually is a very low bar for additivity. So these are kind of the two extremes for it. You can also look at additivity from the point of view of potency or input, how much actually goes in. The most well-known metric here is Lowe's, when additivity is defined by assumption of dose equivalence. Essentially, it's like proportionality of the drugs. Drug A dose equals to some constant times drug 2. It does require parallel dose response curves, so that is a limitation on applicability of this metric, but nevertheless, it is a very critical one for this class of metrics. And then when we were with my collaborator, Jana Geverts, going through this, we decided that it might be good to have an equivalent to the high single agent, but with potency. So with HSA, additivity's efficacy is as good as the most efficacious monotherapy. With this metric, potency is additive if the potency is as good as the most potent monotherapy. Whatever the metric is, there is one calculation that is done for all of them, however you define your synergy. And you get this coefficient of interaction, which is just a simple ratio of the ratio of the metric, so the predicted additivity by the metric over what you actually observed. And very obviously, if the metric, so if this coefficient is less than 1, that means that your combination did better than expected in additive case, so we classify it as synergy. If they're equal, it's additivity. If it is greater than 1, then it's antagonism. Really, that's the main point here is regardless of the metric, if it's synergistic, we want it to be less than 1. Okay, so we have a lot of metrics. Does it actually matter which one you use? Because maybe they actually give similar enough predictions. And all of these, the blood spilled over the right metric was spilled in vain. Well, to do that, to check that, we are modelers, we can check anything we want. We wrote this little toy model. So D1 is some logistic growth. D1 is a proxy for drug 1. D2 is a proxy for drug 2. This is just as an illustrative exercise. And then we varied our D1 versus D2 and calculated synergy of efficacy for these different values. So by bliss, our synergy of efficacy, the most stringent one, pretty much all combinations are additive to antagonistic. So this coefficient of interaction is positive here, like so this one is over 1, very little, but most of it is kind of synergy of efficacy. If you do it by highest single agent, everything is absolutely the same. But if you quantify it according to this metric, then all of these combinations are additive to synergistic because my coefficient of interaction is less than 1. Sorry, these are not color aligned, but you can look at the numbers. Okay, both of them looking at synergy of efficacy and giving very different classifications. This one with synergy of potency, let's look at lows. Combinations, so range here from antagonistic at low doses to maybe somewhat synergistic. So this one is 0.94, this is 1, so you have the full range. And at least here, this particular model in this particular parameter regime is more sensitive to drug 1 dose. Same here, but with low single dose. Now most combinations are antagonistic with near additivity regions that are driven by drug 2. And so this is, again, this is a 2 example. But it does illustrate that, and this was actually that difference. The labels do reflect exactly what they're meant to reflect. But that really raises a question. If we cannot agree on whether a combination is synergistic, what are we optimizing for when we say we want to optimize synergy? And kind of stepping further back as to what it is that we are doing even. We're really always facing the problem of competing objectives. In any therapy, you're balancing at least 2 things: how well something works, your efficacy, versus what it costs the patient, whether in toxicity or any other metric. And these objectives are obviously always in tension because more drug usually more efficacy, but also more toxicity, like bell-shaped efficacy curves aside. So, and then the question becomes about how do you balance these? Because there is no one solution to this. And instead, so this is where our friends in economics, who are obviously thinking a lot about competing objectives as well, there is a concept called Pareto optimal solution, when one cannot improve one objective without worsening the other. It's also called an inferior solution. What does that mean? So you can plot basically your outcomes for different combinations and what's your expected toxicity, whatever that is, versus your expected efficacy, whatever that is. And then you can build this kind of full trade-off curve. So these are called, in red here are Pareto optimal points, or also called non-inferior solutions. As I said, you cannot improve one without worsening the other. This framework is really helpful because it allows us to separate this mathematical question of what are the possible trade-offs from actual value judgment. What trade-off do we actually prefer? What is it that we are that we're trying to optimize in each particular case? And then a clinician or a sponsor or a team, like for example, if you are in a situation where your max acceptable tox is 0.4, whatever that is, again, that maps onto for you if it's if it is cytokine levels, whatever it is. Then, okay, from this you can read if this is as toxic as I can go, then the best efficacy I can get in such situation is 0.6. If, on the other hand, I have a situation where nothing will work if it's not at 0.8 efficacy, again, however you define that, map of solutions and then make decisions based on whatever it is that you need to, your specific project. Okay, so how does Pareto optimality and these synergy metrics actually come in? Well, you can use synergy of efficacy metrics as proxies for efficacy, and you can use synergy of potency metrics as proxy for toxicity. Again, because if it's more potent, supposedly you need to add less drug, and that can map on to toxicity. And so another thing you can do is rather than picking one metric, because as you saw earlier, different metrics optimize for different things, and that's not necessarily a bad thing. But maybe we can calculate our metric and use it too. And instead of picking one metric, we can build 4 Pareto fronts and then find doses that appear on all of them. So basically, the idea is that maybe we can try to find doses and approaches and protocols that take the best from every metric. And of course, we're searching for doses where these metrics converge. Okay, so this is kind of a lot of theory and graphs and terms. Let's work through an example. This was a mouse experiment that was published a few years ago. The specifics are not entirely important, but nevertheless, let's go through this. There were 2 non-small cell lung cancer cell lines, A549 and H1299, so P53 wild type and P53 negative. There was some protocol. Again, for our purposes right now, it's not entirely important. You can see that 549 was obviously less responsive to the combination than H1299. And the drugs were tested both in monotherapy and in combination. Okay, so we're modelers. We model. Model structure is pretty standard. This is just, okay, this is PK/PD. They did not have PK data reported in that paper. That's fine. We found data in the literature to parameterize for mouse, pembro, and bevacizumab. The pharmacodynamics, again, basic logistic growth with Michaelis-Menten saturation. Doesn't have to be logistic. Pick your favorite tumor growth term. Here, it was good enough for the purposes. Adaptable to whatever question, obviously, and whatever project you're working with. Okay, let's look at how we can apply this here. So this approach of looking for across multiple synergy metrics. So these are our Pareto fronts and all of these red dots. So yes, these are synergy metrics, and they all correspond to a protocol. So we do a mapping of like a simulated protocol and then calculate the corresponding synergy metrics for all of them. Okay, so we get something that looks like this, and this was the original protocol that they tested. As you can see over here already, the Pareto optimal doses, so the ones that appear across all of these 4 fronts, they're not nearly there. And the yellow color, it's TGI, so 1 is 100%. So the previous one for this less responsive type cell type, it was clearly not working very well. So you can get good efficacy here if you go into different space. But if you look at also what's the doses, particularly for pembro here, then that's pretty high. So if I were supporting this project, or we were discussing which way to go, do we continue here or there, probably no go for this cell line. But of course, everybody makes their decisions. Now let's look at H1299. So same thing. This was the original protocol. But now here we have our, so the doses, the protocols that appear across all 4 Pareto fronts. Now here, this is actually looking much more promising. You can have a lower dose of pembro, slightly higher dose of beva, and you're still in a very reasonable TGI region here across all metrics. So that's kind of cool. Also, with this approach, and this is the paper, and I have a citation at the end as well. You can also then play, once the model is parameterized, you can play with different protocols. Sorry. And for example, in here, like as we were testing out, what else you can do? Could you improve it not through just dosing, but also through changing the spacing between doses? Like in this particular case, seems like closer spacing appears to be more synergistic. Interesting. Okay, so this was done a couple of years ago. Because science evolves, we work on projects, we made 2 improvements to this algorithm since it was published in 2023. One is we introduced the notion of also near Pareto optimality, because typically it's binary, it's either on the front or not, but you can have a dose that is microscopically off of the dose, but will still be then tossed aside as not good enough. So we decided that in this case, we are going to include doses with fixed relative distance from the front. So at least we played with different thresholds. 2% seemed to be a reasonable cutoff. A more important improvement that we added was to add a minimal efficacy threshold. You can obviously do the same for toxicity. And the reason is that Pareto optimality actually imposes no floor on tumor kill. Like, yes, these could be your possible solutions, because it is a non-inferior solution, cannot improve one objective without harming the other. But this is, if you have an efficacy of, 0.1, that is not really meaningful, something to work with, but you would still identify it in this analysis as Pareto optimal solution. So we introduced a minimum TGI threshold. Here we picked 60% relative to control. You can do anything you need or choose as to be more appropriate for your project before running the algorithm. Okay, so we addressed the divergence between different synergy metrics. We can make sure that we get the best out of each. Is everything going to work now? Well, no. Because another aspect that we really need to be taken into account is heterogeneity. And I'm not only talking about tumor growth rates and differences in that, but also relative sensitivities to the drug. So there was this wonderful paper from 2017 by Palmer and Zorger, and Adam Palmer has been doing amazing work in looking at the question of additivity versus synergy in clinical data. So this is more if you are stepping back, like our approaches here. But so in a preclinical model, we might identify a region of this mutual drug sensitivity. And they did such a good job with this figure, so why recreate it? This one in yellow. A QSP model, however complex, whatever you're working with, is then optimized for usually these average sensitivities to both monotherapy and combination. But of course, everybody's different. And different people might have different sensitivities. Even different animals can have different sensitivities to the same drugs. So how do you make a decision for a heterogeneous population if you can have a range of sensitivities to each drug or the combination? So this can become a modeling challenge, because when we calibrate models to preclinical data or to most data sets we work with, yes, we might take into account some ranges, PopPK, things like that, but we are usually anchored to a single parameter set. And we might be then optimizing things for this average patient who may not exist. Kind of as an example of from our previous and very simple model of beva and pembro, this was a nominal parameterization. So these were the parameters. And if you look at, just looking at the numbers, or you don't even need to look at the numbers, just the distribution of Pareto optimal, like how many times things appear for different doses. This was for the nominal. If we change the sensitivity to Pembro a little bit, now just you can visually see this map looks very differently, and your 2s and 3s and 4s are now in different spaces. If you do increased sensitivity to Beva relative to the nominal, now you get an entirely different approach, an entirely different output. And actually, I think only this case rediscovers this original protocol that they tested as optimal. So what do we do? Well, again, we're modelers. We can do anything we want. And we want to build a parameter space. So we assume that these drug sensitivity parameters can fall within a distribution. Which distribution and how wide the values are ranging, judgment call every time. In this particular case, we decided that a reasonable approximation, if you don't know what to do but want to test out the methodology, we selected values that produce 50% change in end tumor volume within from these data, both for Pembro monotherapy, for Beva monotherapy, and for the combination. And then, as a result, we can create this beautiful structure, this parameter cuboid. So on the two axes, you have sensitivity, the possible ranges of sensitivity to each drug. On the z-axis is possible sensitivities to the combination. And each dot here is then a plausible patient parameterization with respect to where they could be reasonably relative to average in their sensitivities to these drugs. Then what we can do is discretize the space into voxels, so these subgroups. And we can ask questions now. One of the questions that you can ask is, how do I find good combinations for a known voxel? So finding the right dose for a known patient. If I know the characteristics of my patient, what is going to work for them? Another question you can ask is stratification question by likelihood of responding to a pre-selected dose. So this is a question of, I have a combination, but I want to find people for whom, individual for whom it will work. Okay, so let's look at one question at a time. The right dose for a known patient. If you know to which voxel your patient belongs, what's the right dose for them? This is, I think, the last definition that I'm going to be introducing here, but it's an important one that ties things together. So within each voxel, we seeded them with our 30 possible parameter combinations. So this could be 30 parameterizations, 30 possible individuals. And then we run this algorithm for each. So it's called MOOPS-TS, multi-objective optimization, combination synergy, dose selection. There's a reason for why it was selected this way, MOOPS-TS. And then we calculate what we introduced this Pareto optimality score, which is basically a fraction of these 30 samples for which a given dose is near Pareto optimal across all criterion spaces. So what we're doing is we're trying to bring together and kind of building up all of the aspects that we need to be taken into account. Yes, synergy and different metrics and reconciling different metrics. And now we're reconciling them across multiple individuals and trying to see how we can make this work. And here, if you see, like, it's normalized, a score of 1 means it's robustly optimal for pretty much everyone in the subgroup with respect to every metric. 0 is obviously to none, and then there's the in between. What is really nice, at least in my opinion, about this semi-personalized approach is that you're not looking for one dose for everyone, so it's not fully individualized, but you're also looking for doses that are more applicable for a subgroup. And the reason that I also like the notion of a voxel as opposed to trying to do things more individually is, if nothing else, measurement differences. If you were a little bit off on collecting data or collecting something from a sample, there are lab differences. We know that, for example, positive staining, the classification will be different from lab to lab. There are papers on that. If you didn't get it right with your method, this allows you to have a little bit more of cushion that you're still close enough for this particular individual. Okay, so let's look at a few representative voxels of what this output could look like. I just picked a couple over here, and this output looks like this. So this is a voxel 13 on the top. It's like low PD1, so it classifies them low, high, or medium. So low sensitivity to PD-1, high to VEGF, to beva, and low to combo. Red rectangles is when the dose has reached this is the highest Pareto score across all criterion spaces it can get. And if it's blacked out, it means it didn't meet the efficacy threshold. Here we set it at 60%. You can do whatever you need. Okay, so here one, just visually, this is the space where it is. So it's about 9.72 Pembro, 0.87 Beva, close to actually the original protocol. This individual here from a different voxel, now their dose is much lower on both. And if you can see here, the dose that was really good for this parameterization is actually not even coming up on here. It's like 0.03. Or somebody in voxel 35, it's like moderate, minimal, moderate. Again, different space. And the dose that is really good for them, that was really good for the previous one, does not even show up here. Or this is another example. Because I made this video and it is such a joy for me to look at, so I'm sharing it with you. But you can look at how then these predictions change across voxels as you're going through it. And kind of just general things to point out. So you can see that they are, as you're going through these voxels, you're still kind of concentrated in these areas over here. Like you're not going, well, okay, this one, but then as you're going through them, you're still more in these kind of lower dose regions. So that's kind of interesting. Okay, so that would be one way to look at it. We can find the dose for a known patient. Now, the reverse question: how to find the right patient for a known dose? So, as if you have a fixed combination dose, who is most likely to respond? Well, let's do dose sweeps. I love doing dose sweeps because, again, as modelers, we can. So we create this dose grid, and we have like subdivided beva doses on the x-axis, and we have possible pembro doses on the y-axis. Again, the specific numbers here are not as important. They were calibrated to that experiment that we got from the literature. But to give an idea. And then for each dose combination in the grid, we will calculate Pareto optimality score across all the voxels. So again, it's very computationally intensive, but that's why we have clusters. And as a result, you have this map of a parameter space colored by how well a particular dose serves each subgroup. So what does that look like? Color bar here is optimality score across spaces. So one is, as we talked about, where you want to be. You want to be yellow. You do not really want to be blue. For all intents and purposes, this is what we're talking about now. And if TGI is not reached, then we are not even plotting these data. So for this particular combination, okay, these are actually relatively low. So 2.7 versus like 0.13. You have a lot of responders, so people who are very likely individuals to respond in this kind of top level, not so much over here. This one, so slightly higher dose on pembro, now you're kind of maybe moving more into the middle of this region. Here, most responders are maybe over here. This is, again, a different dosing space. Here, yes, for everyone, like there are some individuals for whom this combination was identified as Pareto optimal, but the proportion is not very high. Or alternative way to look at the data, that it's not Pareto optimal across all spaces. Once again, let us look at how this looks. If you are looking now, trying to build a bigger picture. Again, we're all building from smaller and kind of simpler exercises up. So I'd like to point out, as we're kind of going through across this space, where all the yellows are concentrated. We see a lot more yellows here in the kind of in this region. And then it kind of moves across. So the yellow's here, and then as you're going through this grid, going towards the middle and towards this side over here. Oops, sorry. Okay. So if you were to then, again, do not be alarmed. I will show what I need to show on here. If you were to actually look at all of these data, you remember I was talking, I'm just basically looking for the yellows, and I'm looking for the regions in which we are most likely to find responders, whoever they may be. Then yes, so these are kind of the spaces where you're more likely to have our yellow classifications. And as I was saying, so here yellow is kind of in the top left, going towards the middle, going towards the bottom, but at least this can say this is a region probably where we should be fishing. And within that region, you might have different classifications of responders. Okay, that is wonderful. One big problem. How do you know to which voxel a person belongs? Well, you do it by assigning how do you assign a voxel space? Well, best case scenario, you have some kind of a measurable biomarker. Or maybe you have some wonderful genomic drug sensitivity score, and you can map that if somebody has these genes expressed, that they might be more sensitive to this or that. If you don't, we can still try to find some solutions. And one idea that we're proposing, this is kind of theoretical, but I want to talk through what's the world in which we could do something like this. Idea of an initiation protocol. So let me talk you through this. Let's assume we're in a preclinical space right now, collect some information on intrinsic tumor growth rate prior to treatment, so to get our growth rate parameters. Then you measure tumor volume and administer the drug. We suggest with a shorter half-life, the way that we were trying to design this idealistic experiment is to try to make sure that it's as realistic as possible. Sorry, somebody is on mute. Not sure what to do there. Okay, let's keep going. You let the drug clear so again, we're proposing either under 90% of Cmax or till LLQ. Essentially, you needed to clear enough for you to be able to quantify the effect of monotherapy.
Somebody is.
I am not sure what is happening. Heather or Mike, can you please
check? Well,
things?
if your audio is on, would you mind muting, except for the speaker? It sounds like we're getting some background interference.
Yeah, thank you. Okay, so you fit the drug, and so here you're able to fit the drug kill rate parameter and test the sensitivity. And the beautiful thing here, we were trying to also make sure that the way that we are designing this kind of hypothetical protocol is that our parameters would be identifiable. So you have confidence in your estimations. Okay, then you can measure tumor volume, give the drug with a longer half-life. Now you do not need to wait this long for the drug to clear, because the issue earlier is you can have confounded effects, and you might have a little bit of the effect of the previous drug there. But here you kind of have estimated that as well. So now you're just fitting one more parameter at a time. Now we can do it for the second drug, and then finally administer the combination and try to then fit the combination kill rate parameter and test the sensitivity. And we're looking for the thresholds that require the least time. Here it's like surpass Cmax for both drugs seems to be good enough to be able to identifiably fit these parameters. The beauty of this approach is that the parameter is identifiable. So if you structure your experiment correctly with planning for this, the right data collection sequence can allow you to estimate them with confidence. I mean, there are obvious caveats here. You need to be able to see the effect to be able to estimate the parameters to actually get the dose response. So if there's a delay, you might need to adjust this approach. Does not yet take into account emergence of resistance. We're working on this. It's actually a very exciting kind of extension that we're looking into. How do you plan for something like this? Because with each next dose, the tumor is a little bit different than it was at previous dosing. We tend to ignore that, frankly, in a lot of the modeling that we do in this field. But if we did not, how would the predictions change? But in general, this is a framework. So the details are worked out individually for each project, but this nevertheless allows us to kind of a way to think about this. Okay, so can we now solve the preclinical translation problem? We have a robust approach to reconciling different synergy metrics. We can take into account patient heterogeneity. Like, can we expand the funnel now? you know where this is going, which is kind of, maybe. But before we get to that, I really want to circle back to what does synergy actually do? If we are looking and how do we deal with combinations? What does being synergistic actually translate to? And this is an important question because when we are optimizing for synergy, and this required kind of a certain mental adjustment for me, because there is, I think, for most of us, this false equivalency that if something is synergistic, then it will be the longest time to progression or the highest tumor burden. But that's not what synergy optimizes for. When we're optimizing for synergy, we are optimizing them to bring out the best in each other. It may be the same thing. It might map onto longest TTP. It might translate to highest tumor burden. It might not. It's not the same. And that's why when we are doing it here, we introduce this efficacy and again, the toxicity cutoff as well, so we can stay in the region that would actually be meaningful. That does not make synergy a bad criterion, absolutely not. But maybe what we really should be doing here is something broader, which is multi-objective optimization, and where synergy is really just a subset of the kinds of questions we can ask here. Because really, when we are optimizing for things, and then this is going back to this false equivalency of synergy is not the same as better outcome necessarily. So maybe we can step back as the real question is, what is the outcome that we care about? And what is the real trade-off that we are navigating? And I would argue that multi-objective optimization with heterogeneity is the correct structure for this question, but what goes on the axis is actually not that relevant as context dependent. Like if you have clinical endpoints, you can just optimize for, okay, how do you balance progression-free survival, longest progression versus specific tox, or TGI versus tox, neutropenia, cytokine levels, etc. If you can put specific numbers that are all, like, what matters is that they're tied to the dose, to your protocol, and to your drug's activity. But otherwise, you can map onto it whatever you need, whatever you have. If you have a mechanistic question that is not yet at the clinical stage, the synergy metrics with thresholds are a perfectly adequate and good way to approach this, balancing this out. You can do this with, if you have Emax, Tmax criteria, if you have whatever your Tmax criteria, your exposure, whatever it is that you're doing, versus your Emax, TGI. Again, that does not matter because this framework scales to data, whatever you need, but the underlying structure remains the same. So what does this mean across indications? And I have maybe 2 or 3 more slides left, so we have enough time for questions. The axis can take different forms depending on disease area. I do not need to go through them. This is thankfully recorded, so you can look into it if you need. But in general, like in solid tumors, we can look at TGI versus exposure or toxicity probability. It does not also, you can put your categorical or continuous variables on it. It does not matter. What matters is the structure. In hematology, maybe you are looking at MRD versus time to neutrophil recovery. In immuno-oncology, like you might not get early response rates. So this is this delay that we were talking about. Maybe something like durable response rate versus immune-related adverse event probability. In infectious diseases, maybe you have viral suppression versus emergence of resistance probabilities. Anything that could be a meaningful question that is connected to your dose can be put in there. Metabolic disease, CNS pain. You can find anything because the pattern, what matters here is the pattern that remains the same in every case. On one axis, you have how well does this work for this patient. On the other, what does it cost the patient? And then you're trying to find the best possible combination of these for your specific case. So this one is a little bit more theoretical, but stay with me. I would love actually feedback on and thoughts on this, because can we, if we are going, like we are doing intelligent trial design and model guided trial design, can we bring this idea of an initiation protocol into a broader clinical concept? Because if you know what parameters matter for your stratification, again, something that we as modelers can contribute to, try to figure out, you can design your early trial phases to estimate them. Or maybe you can do something even kind of more interesting. Maybe your phase 1 could be on structured monotherapy phase is to actually estimate those patient-specific parameters to then assign them to a biological group. And then in phase 2, you get to some kind of, you actually do the combination dose selected based on the subgroup assignment. Maybe this is something that could connect to the FDA's, of course, Complex Innovative Trial Designs Program model and MIDD framework. Again, this is not maybe entirely conventional, but is this really is just throwing the drug combination at everybody without knowing that this could happen? Is that the best case? The best way to approach it? I don't know. Okay, some closing thoughts. As you heard, I love actually economics research. I do find that cross-pollination of questions is very wonderful and interesting in there. And actually the types of questions and optimization and trade-off questions that are addressed in economics do map onto our field as well, quite well. And Esther Duflo, who won the Nobel in economics in 2019, one of her big theses was that economists need to think like plumbers. Like economist as a plumber, I think is the name of the essay. And the idea is that it's not just, yes, they develop beautiful theories about how things work or how people's psychology will work, or this and that. But really, to make this work, you need to get into the specific pipes of each situation. Think of it as a plumber. Yes, I have a plan, but oh, there's a root here, there's a bend here. You design your approach for actual specific situation, even if you have a bigger theoretical roadmap. And I would argue that we as modelers, as QSP modelers, should also be thinking as plumbers. Like here, this is a very general framework. It's multi-objective optimization, patient stratification, MIDD. You can do this, obviously, it's not just combinations. It's applicable to anything that we are working on because that is what we're doing in drug design. But the specifics are to be worked out for each situation. Like whatever goes on the axes, whatever model structure, whatever thresholds are applicable here, what biological variability. And it's not no plug and play algorithm really can navigate this, I would argue, on the level of complexity that we're often dealing with, which doesn't mean that we can't have a general approach. It's just maybe more specific and individualized for each combination or each specific situation. And so this is kind of my answer, my hope for how to actually increase our chances of translating preclinical promise into clinical success. Okay, that's all I got. Thank you so much. And thank you, of course, to my incredible collaborator, Dr. Geverts. These are some of the key references. If you want to talk to me at some point, please do. I love talking science. Thank you.
Thank you so much, Irina. That was an excellent presentation. We do have a couple of questions. First one is a question about the evaluation of drug synergy. Since synergistic effects can be time dependent, could focusing on a single fixed endpoint potentially overlook important synergistic dynamics over time?
That is an excellent question. I'm thinking. So, yes. The short answer is yes. I'm trying to think how that could be mitigated. And the way that I am envisioning right now, as I'm spitballing, is you can take snapshots at maybe different things that are, so as we're running our simulations or going through things, looking at snapshots of what happens at 10 days, 15 days, I don't know, 3 weeks, and try to add yet another layer of complexity to this as you are building another dimensionality to it. But again, we're modelers. As long as we have cluster space, we can do anything.
Yeah, I think you could also envision using different biomarkers predictive of efficacy at different time points as well, if you wanted to look at just basically another outcome that is an output from the analysis that could change over time, and you could have early predictors versus ones that evolve later.
So I'm envisioning right now it would be more like a surface. Probably a multidimensional surface where you are trying to put together just a lot of these slices. One of the problems then we have to translate is how to make it usable. Because
to visualize
we can't come up with anything, but then I can come up with anything, but then I need to be able to communicate it and to distill it into actionable items that do not, frankly, require deep understanding of all of the layers in order for somebody to actually be able to implement it. And that's doable, but that is another one of those plumbing exercises that has to be done as we're communicating with different stakeholders and different people along the drug development pipeline.
Thank you. Another question. It's nice that the model accounts for patient heterogeneity to predict individual responses. Do you also quantify the uncertainty? Uh, in other words, parameters in those predictions. For example, does the model propagate uncertainty to the outputs, such as through confidence intervals or prediction intervals? Does that
We
make
did
sense?
not do that.
Okay.
This is so it's interesting because this is the second time this question comes up, so now it requires extra thought. Because the way that I think of this is by introducing this heterogeneity, the way that we do, like essentially building a virtual population, that is how we don't quantify uncertainty per se, but we plan for it, or we mitigate uncertainty in predictions by essentially simulating a bajillion different cases and
Mhm.
collecting statistics across them. Since this is more like this is the second time I'm hearing this question, I think I'm going to need to think more if maybe there's something I'm missing on that the virtual population approach is not covering. Or maybe another option is that like this is my VP approach, and then there's more statistical approach, and then we're just talking past each other and actually essentially doing the same thing. I'll need
Yeah, I
to,
can imagine
whoever you are, I will think about it.
that.
We'll resolve it one way or another.
Okay, another question, and this is in the cancer world, but actually many therapeutic areas. You have individual patient variability in terms of their physiology and pathophysiology, but you also may have diversity in the background or historical treatments that they've received when they get into a trial. So you may be testing, your two drugs that you're hoping to see synergy, but you also may be dealing with a patient that's been on background drugs or other cancer therapies that have been tried. In this case, how can you, and this is a patient variability question, how can you incorporate that type of analysis or factor in your analyses?
Also, a very interesting question. One thing that I am like my hypothesis would be if we are able to do the initiation stratification piece by actually measuring how this particular individual responds to this or that monotherapy, we don't have to guess what was done to their tumor through previous treatments, but you can actually say, okay, this is who you are at this point in time.
Mhm.
This is what your individual parameters are. Because really, the point of knowing all of that background history is so we can guess where are you going to fall in the sensitivity space. But if we are
Mhm.
actually able to take that and figure out some practical way to measure these, like maybe in this adaptive trial design, maybe then it does not matter as much because you're able to work with individual at this time point as opposed to whatever you can infer about them based on their history.
Thank you. And then a final question. Um, can you incorporate the convenience of different dosing regimens versus others in this type of analysis? For example, every 2 weeks, giving both drugs at the same time might be very convenient for the patient and the physician, but staggering them or giving them multiple times a day or something like that might be very inconvenient. So even though you might have an optimal treatment regimen, it might be very suboptimal in terms of the patient adherence.
Absolutely. And this is so for one, the short answer is absolutely. Because again, the point is, as I was saying, it's not there's a mathematical question of what is the optimal thing, but in the end, like the difference between being efficacious and being effective. I can find you the
Yes.
most efficacious protocol. If the patient is not able to stick to it, it's not effective. Therefore, it's
Yeah.
irrelevant. And so yes, absolutely. We can find and sweep any constraint, but then select only those out of our possible solutions that will be feasible. Alternatively, one can make an argument. Yes, we can do this one. But if, for example, you are able to, and I know, take this one other measurement, the quality of the prediction and your stratification can be so much greater, then maybe then this becomes worth it. If not, then this is what I can recommend for you.
Great.
So one can have all of these like play around along my Pareto optimality front.
Thank you. I'd like to take the time to thank our speaker today, Irina Kareva. Feel free to contact her with any additional questions. The recording of this webinar will be posted on the ROSA website within a day or two. And please feel free to check the website for upcoming webinars, and please contact us if you're interested in being a speaker. Thank you for joining today, and we'll see you next month. Thank you.
Thank you so much.